Chapter 14, The Lymphatic System and Immunity. A child falls and scrapes her knee. Is this likely to be a life-threatening injury? Probably not, even though the breaks in the skin have permitted the entry of thousands or even millions of bacteria. Those bacteria, however, will be quickly destroyed by the cells and organs of the lymphatic system. Although the lymphatic system may be considered part of the circulatory system, we will consider it separately because its functions are so different from those of the heart and blood vessels. Keep in mind, however, that all of these functions are interdependent. The lymphatic system is responsible for returning tissue fluid to the blood and for protecting the body against foreign material. The parts of the lymphatic system are the lymph, the system of lymph vessels, and lymphatic tissue, which includes lymph nodes and nodules, the spleen, and the thymus gland. Lymph is the name for tissue fluid that enters lymph capillaries. Filtration in capillaries creates tissue fluid from blood plasma, most of which returns almost immediately to the blood in the capillaries by osmosis. Some tissue fluid, however, remains in interstitial spaces and must be returned to the blood by way of the lymphatic vessels. Without this return, blood volume and blood pressure would very soon decrease. The system of lymph vessels begins as dead-end lymph capillaries found in most tissue spaces. Lymph capillaries are very permeable and collect tissue fluid and proteins. Lacteals are specialized lymph capillaries in the villi of the small intestine. They absorb the fat-soluble end products of digestion, such as fatty acids and vitamins A, D, E, and K. Lymph capillaries unite to form larger lymph vessels, whose structure is very much like that of veins. There is no pump for lymph, as the heart is the pump for blood, but the lymph is kept moving within lymph vessels by the same mechanisms that promote venous return. The smooth muscle layer of the larger lymph vessels constricts, and the one-way layer of the larger lymph vessels constricts. And the one-way valves, just like those of the veins, prevent backflow of lymph. Lymph vessels in the extremities, especially the legs, are compressed by the skeletal muscles that surround them. This is the skeletal muscle pump. The respiratory pump alternately expands and compresses the lymph vessels in the chest cavity and keeps the lymph moving. Where is the lymph going? Back to the blood to become plasma again. The lymph vessels from the lower body unite in front of the lumbar vertebrae to form a vessel called the cisterna chyli, which continues upward in front of the backbone as the thoracic duct. Lymph vessels from the upper left quadrant of the body join the thoracic duct, which empties lymph into the left subclavian vein. Lymph vessels from the upper right quadrant of the body unite to form the right lymphatic duct, which empties lymph into the right subclavian vein. Flaps in both subclavian veins permit the entry of lymph but prevent blood from flowing into the lymph vessels. Lymphatic tissue consists mainly of lymphocytes in a mesh-like framework of connective tissue. Various numbers of stem cells are present. Recall that after birth, most lymphocytes are produced from stem cells in the red bone marrow, then migrate to the lymph nodes and nodules, to the spleen, and to the thymus. In these structures, lymphocytes become activated and proliferate in response to infection. This is a function of all lymphatic tissue. The thymus has stem cells that produce a significant portion of the T lymphocytes. Lymph nodes and nodules are masses of lymphatic tissue. Nodes and nodules differ with respect to size and location. Nodes are usually larger, 10 to 20 millimeters in length, and are encapsulated. Nodules range from a fraction of a millimeter to several millimeters in length and do not have capsules. Lymph nodes are found in groups along the pathways of lymph vessels, and lymph flows through these nodes on its way to the subclavian veins. Lymph enters a node through several different lymph vessels and leaves through one or two efferent. vessels. As lymph passes through a lymph node, bacteria and other foreign materials are phagocytized by fixed or stationary macrophages. Plasma cells develop from B lymphocytes exposed to pathogens in the lymph and produce antibodies. These antibodies will eventually reach the blood and circulate throughout the body. There are many groups of lymph nodes along the lymph vessels throughout the body, but 3 paired groups deserve mention because of their strategic locations. These are the cervical, axillary, and inguinal lymph nodes. Notice that these are at the junctions of the head and extremities with the trunk of the body. Breaks in the skin with entry of pathogens are much more likely to occur in the arms or legs or head rather than in the trunk. If these pathogens get to the lymph, they will be destroyed by the lymph nodes before they get to the trunk and before the lymph is returned to the blood in the subclavian veins. You may be familiar with the expression swollen glands, as when a child has strep throat, an inflammation of the pharynx caused by Streptococcus bacteria. These glands are the cervical lymph nodes that have enlarged as their macrophages attempt to destroy the bacteria in the lymph from the pharynx. Lymph nodules are small masses of lymphatic tissue found just beneath the epithelium of all mucous membranes. The body systems lined with mucous membranes are those that have openings to the environment, the respiratory, digestive, urinary, and reproductive tracts. You can probably see that these are also strategic locations for lymph nodules, because any natural body opening is a possible portal of entry for pathogens. For example, if bacteria in inhaled air get through the epithelium of the trachea, lymph nodules with their macrophages are in position to destroy these bacteria before they get to the blood. Some of the lymph nodules have specific names. Those of the pharynx are called tonsils. The palatine tonsils are on the lateral walls of the pharynx. The adenoid or pharyngeal tonsil is on the posterior wall, and the lingual tonsils are on the base of the tongue. The tonsils therefore form a ring of lymphatic tissue around the pharynx, which is a common pathway for food and air for the pathogens they contain. The tonsillectomy is the surgical removal of the palatine tonsils and the adenoid, and may be performed if the tonsils are chronically inflamed and swollen, as may happen in children. As mentioned earlier, the body has redundant structures to help ensure survival if one structure is lost or seriously impaired. Thus, there are many other lymph nodules in the pharynx to take over the function of the surgically removed tonsils. The lymph nodules of the small intestine are called Peyer's patches, and despite their small size, they are extremely important. From the time we are born and every day thereafter, hundreds of foreign proteins enter the body by way of the mouth. Absorption of nutrients takes place in the small intestine. Foreign proteins and peptides in foods are absorbed as well, and they are picked up by the roaming dendritic cells and brought to the lymphocytes in the nearest lymph nodule. In infancy, the lymphocytes develop tolerance for proteins from food while retaining their destructive potential for pathogens. The bacteria of the intestinal microbiome are believed to contribute to this ability, though exactly how is not yet known. What is known is that without such tolerances, allergies to common foods may develop. The lymphocytes of Peyer's patches learn to distinguish friend, that is, food, from foe. Hodgkin's disease is a malignant disorder of the lymph nodes. The cause is not known. The first symptom is usually a swollen but painless lymph node, often in the cervical region. The individual is prompted to seek medical attention because of other symptoms, chronic fever, fatigue, and weight loss. The diagnosis involves biopsy of the lymph node and finding of the characteristic cells. Treatment of Hodgkin's disease requires chemotherapy, radiation, or both. With early diagnosis and proper treatment, this malignancy is often very curable. The spleen is located in the upper left quadrant of the abdominal cavity, just below the diaphragm, behind the stomach. The lower rib cage protects the spleen from physical trauma. In the fetus, the spleen produces red blood cells, a function assumed by the red bone marrow after birth. After birth, the spleen is very much like a large lymph node, except that its function affects the blood that flows through it rather than the lymph. The function of the spleen after birth contains plasma cells that produce antibodies to foreign antigens, contains monocytes and fixed macrophages, RE cells, that phagocytize pathogens or other foreign material in the blood. The macrophages of the spleen also phagocytize old red blood cells and form bilirubin. By way of portal circulation, the bilirubin is sent to the liver for excretion in bile. The monocytes of the spleen may enter circulation when tissue is damaged and in need of cleanup and repair, stores platelets, and destroys them when they are no longer useful. The spleen is not considered a vital organ because other organs compensate for its function if the spleen must be removed. The liver and red bone marrow will remove old blood cells and platelets from circulation. The many lymph nodes and nodules will phagocytize pathogens, as will the liver, and have lymphocytes to be activated and plasma cells to produce antibodies. Despite this redundancy, a person without a spleen is somewhat more susceptible to certain bacterial infections such as pneumonia and meningitis. The thymus is located inferior to the thyroid gland. In the fetus and infant, the thymus is larger and extends beneath the sternum. With increasing age, the thymus shrinks, and relatively little thymus tissue is found in adults, though it is still active. The stem cells of the thymus produce T lymphocytes or T cells. Their specific functions are discussed in the next section. Thymic hormones are necessary for what may be called immunological competence. To be competent means to be able to do something well. The thymic hormones and other cells of the thymus enable the T cells to participate in the recognition of foreign antigens and to provide immunity. This ability of T cells is established early in life and then is perpetuated by the lymphocytes themselves. But what exactly do the T cells learn that makes them competent? In the thymus, immature T cells are introduced to the cells and organic molecules of the body and develop two capabilities: self-recognition and self-tolerance. Self-recognition is the ability to distinguish the cells that belong in the body from those that do not. Some of the immature T cells react with the cell membrane self proteins on the cells of the thymus and learn them. These are the antigens of the major histocompatibility complex, MHC, also called HLA on the white blood cells. All of our cells have these proteins, so these T cells will accept all of a person's cells as belonging. T cells that do not do this will undergo apoptosis, programmed cell death. Self-tolerance is the ability not to react to proteins and other organic molecules our cells produce. Immature T cells interact with dendritic cells of the thymus that have collected such self-molecules. The T cells that do not react to these molecules, but rather accept or tolerate them, are the ones that will survive. Those T cells that do react will be inactivated and destroyed. All of these introductions in the thymus begin taking place during fetal development, but the newborn's immune system is not yet fully mature, and infants are more susceptible to certain infections than are older children and adults. Usually by the age of 2 years, the immune system matures and becomes fully functional. This is why some vaccines, such as measles, are not recommended for infants younger than 15 to 18 months of age. Their immune systems are not mature enough to respond strongly to the vaccine, and the protection provided by the vaccine may be incomplete. Immunity may be defined as the ability to destroy pathogens or other foreign material and to prevent further cases of certain infectious diseases. This ability is of vital importance because the body is exposed to pathogens from the moment of birth. Antigens are chemical markers that identify cells. Human cells have their own antigens that identify all the cells in an individual as self, the HLA types, which are on the white blood cells. When antigens are foreign or non-self, they may be recognized as such and destroyed. Bacteria, viruses, fungi, and protozoa are all foreign antigens that activate immune responses, as are cell products such as bacterial toxins. Malignant cells, which may be formed within the body as a result of mutations of normal cells, are also recognized as foreign and are usually destroyed before they can establish themselves and cause cancer. Unfortunately, transplanted organs are also foreign tissue, and the immune system may reject or destroy a transplanted kidney or heart. Sometimes the immune system mistakenly reacts to part of the body itself and causes an autoimmune disease. Several of these were mentioned in previous chapters. Most often, however, the immune mechanism functions to protect the body from the microorganisms around us and within us. Immunity has two main components, innate immunity and adaptive immunity. Before we describe each component, a brief general comparison may be helpful. Innate immunity may be called nonspecific. It does not create memory, and its responses are always the same regardless of the target. Adaptive immunity is very specific as to its target. It may involve antibodies. It does create memory, and it may become more efficient. Both kinds of immunity work together to prevent damage and disease. Innate immunity has several aspects: anatomic and physiological barriers, phagocytic and other defensive cells, and chemical secretions and reactions, including inflammation. Although we will describe each aspect separately, keep in mind that they all work together. There is also a great deal of overlapping among the three aspects, as you will see. The innate immune responses are always the same, and their degree of efficiency does not increase with repeated exposure. The stratum corneum of the epidermis of the skin is non-living, and when unbroken is an excellent barrier to pathogens of all kinds. The microbiota of the skin surface and the fatty acids in sebum help limit the growth of some pathogenic bacteria on the skin. The living cells of the epidermis produce defensins, which are antimicrobial chemicals. The mucous membranes of the respiratory, digestive, urinary, and reproductive tracts are living tissue, yet still a good barrier. The ciliated epithelium of the upper respiratory tract is an especially effective barrier. Dust and pathogens are trapped on the mucus. The cilia sweep the mucus to the pharynx, and it is swallowed. The hydrochloric acid of the gastric juice destroys most pathogens that enter the stomach, either in mucus or with food and drink. Lysozyme, an enzyme found in saliva and tears, inhibits the growth of bacteria in the oral cavity and on the warm, wet surface of the eye. The subcutaneous tissue contains many white blood cells, as does the areolar connective tissue found below the epithelium of mucous membranes. Recall from Chapter 11 that many of our defensive cells are white blood cells. Macrophages, both fixed and wandering, have receptors for the pathogens humans are likely to encounter. This probably reflects millions of years of coexistence and are very efficient phagocytes. Other cells capable of phagocytosis of pathogens or other foreign antigens are neutrophils and, to a lesser extent, the eosinophils. Phagocytic cells use intracellular enzymes and chemicals such as hydrogen peroxide to destroy ingested pathogens. The Langerhans cells of the skin and the many other Dendritic cells throughout the body also phagocytize foreign material, not merely to destroy it, but to take it to a lymph node or nodule where the lymphocytes of adaptive immune mechanisms are then activated. The macrophages are also involved in activating these lymphocytes. This is a very important link between the two components of immunity. Natural killer cells, or NK cells, circulate in the blood but are also found in the red bone marrow, spleen, and lymph nodes. They are a small portion, about 10%, of the total lymphocytes, but are able to destroy many kinds of pathogens and tumor cells. NK cells make direct contact with foreign cells and kill them by rupturing their cell membranes with chemicals called perforins, or by inflicting some other kind of chemical damage. Basophils and mast cells, a type of connective tissue cell formed in the red bone marrow, are also defensive cells that are found throughout the areolar connective tissue of mucous membranes and the subcutaneous tissue. They produce histamine and leukotrienes. Histamine causes vasodilation and makes capillaries more permeable. These are aspects of inflammation. Leukotrienes also increase capillary permeability and attract phagocytic cells to the area. Chemicals that help the body resist infection include the interferons, a complement proteins, and the chemicals involved in inflammation. The interferons, alpha, beta, and gamma interferons, are proteins produced by cells infected with viruses and by T cells. Viruses must be inside a living cell to reproduce, and although interferon cannot prevent the entry of viruses into cells, it does block their reproduction. When viral reproduction is blocked, the viruses cannot infect new cells and cause disease. Interferon is probably a factor in the self-limiting nature of many viral diseases, and has been used in the treatment of some diseases such as hepatitis C. Complement is a group of more than 20 plasma proteins that circulate in the blood until activated. They are involved in the lysis of cellular antigens and the labeling of non-cellular antigens. Some stimulate the release of histamine in the inflammation. Others attract white blood cells to the site. Inflammation is a general response to damage of any kind, microbial, chemical, or physical. Basophils and mast cells release histamine and leukotrienes, which affect blood vessels as previously described. Vasodilation increases blood flow to the damaged area, and capillaries become more permeable. Tissue fluid and white blood cells collect at the site. The purpose of inflammation is to try to contain the damage, keep it from spreading, eliminate the cause, and permit repair of the tissue to begin. From even this brief description, you can see why the 4 signs of inflammation are redness, heat, swelling, and pain. Redness is visible in light skin and, of course, not all internally. It is the result of greater blood flow. Heat also comes from increased blood flow and greater metabolic activity. Swelling comes from the accumulation of tissue fluid, and pain from the damage itself and perhaps the swelling. As mentioned in Chapter 10, inflammation is a positive feedback mechanism that may become a vicious cycle of damage and more damage. The hormone cortisol is one brake that prevents this, and at least one of the complement proteins has this function as well. There are probably other chemical signals, in general called cytokines and chemokines, that help limit inflammation to an extent that is useful. In summary, innate immunity is nonspecific as to pathogen. It is always the same. It does not create memory, and though very often effective, it does not become more efficient upon repeated exposures. Some cells of innate immune mechanisms also activate the adaptive immune mechanisms. To adapt means to become suitable, and adaptive immunity can become suitable for and respond to almost any foreign antigen. Adaptive immunity is specific and carried out by lymphocytes and macrophages. The majority of lymphocytes are the T lymphocytes and B lymphocytes, or more simply, T cells and B cells. In the embryo, T cells are produced in the bone marrow and thymus. They must pass through the thymus, where the thymic hormones bring about their maturation, that is, the ability to distinguish between self and non-self. The T cells then migrate to the spleen, lymph nodes, and lymph nodules, where they are found after birth. Produced in the embryonic bone marrow, B cells migrate directly to the spleen and lymph nodes and nodules. When activated during an immune response, some B cells will divide many times and become plasma cells that produce antibodies to a specific foreign antigen. The mechanisms of immunity that involve T cells and B cells are specific, meaning that one foreign antigen is the target each time a mechanism is activated. A macrophage has receptor sites for foreign chemicals such as those of bacterial cell walls or flagella, and may phagocytize just about any foreign material it comes across, as well as the Langerhans or dendritic cells. T cells and B cells, however, become very specific, as you will see. The first step in the destruction of a pathogen or foreign cell is the recognition of its antigens as foreign. Both T cells and B cells are capable of this, but the immune mechanisms are activated especially well when this recognition is accomplished by macrophages and a specialized group of T lymphocytes called helper T cells, also called CD4 T cells. The foreign antigen is first phagocytized by a macrophage, and parts of it are presented on the macrophage's cell membrane. Also on the macrophage membrane are self-antigens that are representative of the antigens found on all of the cells of the individual. Therefore, the helper T cell that encounters this macrophage is presented not only with the foreign antigen, but also with self-antigens for comparison. The helper T cell becomes sensitized to and specific for the foreign antigen, the one that does not belong in the body. The recognition of an antigen as foreign initiates one or both of the mechanisms of adaptive immunity. These are cell-mediated immunity, sometimes called simply cellular immunity, in which T cells and macrophages participate, and antibody-mediated immunity, or humoral immunity, which involves T cells, B cells, and macrophages. The mechanism of immunity does not result in the production of antibodies, but it is effective against intracellular pathogens such as viruses, fungi, malignant cells, and grafts of foreign tissue. As mentioned earlier, the first step is the recognition of the foreign antigen by macrophages and helper T cells, which become activated and are specific. These activated T cells, which are antigen-specific, divide many times to form cytotoxic killer T cells, also called CD8 T cells and memory T cells. Cytotoxic T cells are able to chemically destroy foreign antigens by disrupting cell membranes. This is how cytotoxic T cells destroy cancer cells or cells infected with viruses to prevent the viruses from reproducing. These T cells also produce cytokines, which are chemicals that attract macrophages to the area and activate them to phagocytize the foreign antigen and cellular debris. The memory T cells will remember the specific foreign antigen and become active if it enters the body again. Besides being activated or started appropriately, these immune responses must be stopped when their targets have been eliminated. This is important because an excessive immune response by T cells can be very damaging to tissues and, depending on the organs damaged, such as the liver or heart or kidneys, may be fatal for the person in as little as 48 hours. Yes, our very own T cells can kill us. A subset of CD4 T cells called regulatory T cells, once called suppressor T cells, produces feedback chemicals that limit the immune response once the foreign antigen has been destroyed. The memory T cells, however, will quickly initiate the cell-mediated immune response should there be a future exposure to the antigen. The mechanism of immunity does involve the production of antibodies. The first step is the recognition of the foreign antigen, this time by B cells, as well as by macrophages and helper T cells. The sensitized helper T cell presents the foreign antigen to B cells, which provides a strong stimulus for the activation of B cells specific for this antigen. The activated B cells begin to divide many times, and two subsets of cells are formed. Some of the new B cells produced are plasma cells that produce antibodies specific for this one foreign antigen. Other B cells become memory B cells, which will remember the specific antigen and initiate a rapid response upon a second exposure. Antibodies, also called immune globulins, Ig, immunoglobulins, or gamma globulins, are proteins shaped somewhat like the letter Y. Antibodies do not themselves destroy foreign antigens, but rather become attached to such antigens to label them for destruction. Each antibody produced is specific for only one antigen. Because there are so many different pathogens, you might think that the immune system would have to be capable of producing many different antibodies, and in fact this is so. It is estimated that millions of different antigen-specific antibodies can be produced should there be a need for them. The structure of antibodies is shown in Figure 14.8, and the 5 classes of antibodies are described in Table 14.1. The antibodies produced will bond to the antigen, forming an antigen-antibody complex. This complex results in opsonization, which means that the antigen is now labeled as food for phagocytosis by macrophages or neutrophils. The antigen-antibody complex also stimulates the process of complement fixation. Some of the circulating complement proteins are activated or fixed by an antigen-antibody complex. Complement fixation may be complete or partial. If the foreign antigen is cellular, the complement protein bonds to the antigen-antibody complex, then to one another, forming an enzymatic ring that punches a hole in the cell to bring about the death of the cell. This is complete or entire complement fixation, and is what happens to bacterial cells. It is also the cause of hemolysis in a transfusion reaction. If the foreign antigen is not a cell, let's say it's a virus for example, partial complement fixation takes place, in which some of the complement proteins bond to the antigen-antibody complex. This is a chemotactic factor. Chemotaxis means chemical movement, and is actually another label that attracts macrophages to engulf and destroy the foreign antigen. In summary, adaptive immunity is very specific as to pathogens, does create memory, and, because it does, often becomes more efficient with repeated exposures. Before we continue, let us consider one final comparison of our two major components of immunity. It may be helpful to think of innate and adaptive immunity as teams in a sport such as soccer, baseball, or basketball. If you have a favorite team sport, you know that any good team needs a good defense. The innate immunity team uses the same defense game after game, no matter who the opponent is. The innate immunity team uses the same defense game after game, no matter who the opponent is. Why? Because it is the only strategy the innate immunity team knows, and because it often works. Although it cannot recognize the star player on an opposing team and adapt accordingly, innate immunity is often very effective as a zone defense may be in basketball. Of great importance as well is that the cells of innate immunity activate lymphocytes of the adaptive immune response, as if players on the team were giving a scouting report to the team that will be playing this opponent next week. The adaptive immunity team will focus on and go after the opponent's star player as with a man-to-man defense, and will remember and be prepared for that player should there ever be a rematch. As of late 2017, worldwide, more than 27 million people had died of acquired immunodeficiency syndrome, or AIDS, caused by the human immunodeficiency virus, or HIV, and more than 37 million people are HIV positive or have AIDS. The disease was first described in 1981 among young homosexual men in New York and California. These men had opportunistic infections such as Kaposi sarcoma and pneumocystis pneumonia, and would develop other fungal or protozoan infections that would not occur in those with healthy immune systems. Where did this virus come from? It is likely that HIV evolved from a chimpanzee virus in Africa sometime during the 1930s. Spread of the virus among people was very slow at first, and only when air travel became commonplace did the virus spread worldwide. HIV is a retrovirus that infects helper T cells, macrophages, and many other human cells. Without sufficient helper T cells, the immune system is seriously impaired. Pathogens are not recognized as foreign, B cells are not activated, and killer T cells are not stimulated to proliferate. Although some opportunistic infections may be treated with medications and even temporarily cured, the immune system cannot prevent the next infection or the next. The incubation period of AIDS is highly variable, ranging from a few months to several years. An infected person may unknowingly spread HIV to others before any symptoms appear. It should be emphasized that AIDS, although communicable, is not a contagious disease. It is not spread by casual contact as is measles or the common cold. Transmission of AIDS occurs through sexual contact, by contact with infected blood, or by placental transmission of the virus from mother to fetus. In the United States, most of the cases of AIDS during the 1980s were in homosexual men and IV drug users who shared syringes contaminated with their blood. By the 1990s, however, it was clear that AIDS was a heterosexually transmitted as well. In much of the rest of the world, especially Africa and Asia, the transmission of AIDS has always been primarily by heterosexual contact, with equal numbers of women and men infected. In many of these countries, AIDS remains a serious public health problem. As of this writing, AIDS is still an incurable disease. At present, we have no medications that will eradicate HIV, although certain combinations of drugs effectively suppress the virus in some people. For these people, AIDS may become a chronic but not fatal disease. Unfortunately, the medications do not work for everyone, and they are very expensive, placing them beyond the means of most of the world's AIDS patients. We have no vaccine for AIDS yet, despite extensive ongoing work. HIV is a mutating virus. It constantly changes itself, making previously produced antibodies ineffective. Even a healthy immune system might find it difficult to keep up with such a rapidly mutating virus, and an impaired immune system simply cannot. A constant antigen, one that does not change and could be used in a vaccine, has not yet been discovered. Behavioral prevention remains extremely important, and that requires education. Everyone should know how AIDS is spread and know the high-risk behaviors that make acquiring HIV more likely. Healthcare personnel have a special responsibility not only to educate themselves, but to provide education about AIDS for their patients and the families of their patients, and to encourage HIV testing when appropriate. Classes of antibodies: IgG, blood and extracurricular fluid; a monomer, the most abundant immune globulin, crosses the placenta to provide passive immunity for newborns, provides long-term immunity to a disease following recovery or a vaccine. IgA, external and internal secretions, tears, saliva, intestinal, etc. A dimer, present in breast milk to provide passive immunity for breastfed infants, found in secretions of all mucous membranes to provide local defense where pathogens enter. IgM, blood, a pentamer, produced first by the maturing immune system of infants, produced first during an infection. IgG production follows, the antibodies of the ABO blood group. IgD, B lymphocytes, a monomer, forms receptors on B lymphocytes. IgE, mast cells or basophils, a monomer, is important in allergic reactions. Mast cells release histamine and responses to parasites such as worms. Several important laboratory tests involve antibodies and may be very useful to confirm a diagnosis. Complement fixation test determines the presence of a particular antibody in the patient's blood but does not indicate when the infection occurred. Antibody titer determines the level or amount of a specific antibody in the patient's blood. If another titer is done 1 to several weeks later, an increase in the antibody level shows the infection to be current. Fluorescent antibody test uses antibodies tagged with fluorescent dyes which are added to a clinical specimen such as blood, sputum, or a biopsy of a tissue. If the suspected pathogen is present, the fluorescent antibodies will bond to it and the antigen-antibody complex will glow when examined with a fluorescent microscope. Tests such as these are used in conjunction with patient history and symptoms to arrive at a diagnosis. The first exposure to a foreign antigen does simulate antibody production, but antibodies are produced slowly and in small amounts. Let us take a specific example, the measles virus. On a person's first exposure to the virus, antibody production is usually too slow to prevent the disease itself, and the person will have clinical measles. Most people who get measles recover and, upon recovery, have antibodies and memory cells that are specific for the measles virus. On a second exposure to this virus, the memory cells initiate rapid production of large amounts of antibodies, enough to prevent a second case of measles. This is the reason why we develop immunity to certain diseases, and this is also the basis for the protection given by vaccines. As mentioned previously, antibodies label pathogens or other foreign antigens for phagocytosis or complement fixation. More specifically, antibodies cause agglutination or neutralization of pathogens before their eventual destruction. Agglutination means clumping, and this is what happens when antibodies bind to bacterial cells. The bacteria that are clumped together by attached antibodies are more easily phagocytized by macrophages. The activity of viruses may be neutralized by antibodies. A virus must get inside a living cell in order to reproduce itself. However, a virus with antibodies attached to it is unable to enter a cell, cannot reproduce, and will soon be phagocytized. Bacterial toxins may also be neutralized by attached antibodies. The antibodies change the shape of the toxin, prevent it from entering its The antibodies change the shape of the toxin, prevent it from exerting its harmful effects, and promote its phagocytosis by macrophages. Allergies are also the result of antibody activity. The purpose of vaccines is to prevent disease. A vaccine contains an antigen that the immune system will respond to, just as it would to the actual pathogen. The types of vaccine antigens are killed or weakened or attenuated pathogen, part of a pathogen such as a bacterial capsule, or an inactivated bacterial toxin called a toxoid. Because the vaccine itself does not cause disease, with very rare exceptions, the fact that antibody production to it is slow is not detrimental to the person. The vaccine takes the place of the first exposure to the pathogen and stimulates production of antibodies in memory cells. On exposure to the pathogen itself, the memory cells initiate rapid production of large amounts of antibody enough to prevent disease. We now have vaccines for many diseases. The tetanus and diphtheria vaccines contain toxoids, the inactivated toxins of these bacteria. Vaccines for pneumococcal pneumonia and meningitis contain bacterial capsules. These vaccines cannot cause disease because the capsules are non-toxic and non-living. There is nothing that can cause harm or reproduce. Influenza and rabies vaccines contain killed viruses. Measles and the oral polio vaccines contain attenuated or weakened viruses. Although attenuated pathogens are usually strongly antigenic and stimulate a protective immune response, there's a very small chance that the pathogen may regain its virulence and cause the disease. The live virus oral polio vaccine, still being used in the quest to eliminate polio throughout the world, has a risk of 1 in 500,000 of causing polio. The killed virus injectable polio vaccine has no such risk. An allergy is a hypersensitivity to a particular foreign antigen, such as an allergen. Allergens include plant pollens, foods, chemicals and cosmetics, antibiotics such as penicillin, and mold spores. Such allergens are not themselves harmful. Most people, for example, can inhale pollen, eat peanuts and shrimp, or take penicillin with no ill effects. Hypersensitivity means that the immune system mistakenly responds and over-responds to the allergen and produces tissue damage by doing so. The development of a food allergy to shrimp is shown in box 14.5. On a first exposure to shrimp protein, the roaming dendritic cells pick up the protein in the mucosa of the small intestine and take it to the T cells in a Peyer's patch. For reasons we do not yet know, a person's T cells may not be able to learn the shrimp protein and tolerate it as food. If that happens, the T cells activate B cells and they produce IgE antibodies to the shrimp protein. These antibodies then bond to mast cells, which contain histamine and leukotrienes. Then, on a second exposure to shrimp protein, the protein bonds to the IgE antibodies on the mast cells, which triggers the release of histamine and other cytokines. These chemicals contribute to inflammation by increasing the permeability of capillaries and venules. In an allergic reaction, however, inflammation serves no useful purpose. It is simply damaging and creates symptoms such as hives or watery eyes and runny nose or hay fever, or the more serious wheezing and difficult breathing that characterizes asthma. Several medications are available to counteract these effects. Anaphylactic shock is an extreme allergic reaction that may be elicited by exposure to penicillin, insect venoms, or certain foods. On first exposure, the person becomes highly sensitized to the foreign antigen. On the second exposure, histamine and other cytokines are released from mast cells throughout the body and cause a drastic decrease in blood volume. The resulting drop in blood pressure may be fatal in only a few minutes. People who know they are allergic to bee stings, for example, may obtain a syringe of epinephrine to carry with them. Epinephrine can delay the progression of anaphylactic shock long enough for the person to seek medical attention. Clinical studies to help the immune system, T cells, learn to tolerate allergens are ongoing. Children with severe, likely to be fatal allergies to milk or peanuts are first given in food a minute amount of the problem protein. The following week they get a little more, then a little more, and so on. After months of these very gradual increases, some children could eat up to a dozen peanuts or drink 6 to 8 ounces of milk. Such studies must proceed slowly and under strict medical supervision. Prevention of certain allergies may be possible in that past thinking about early exposure to allergens may have been mistaken. Recent studies strongly suggest that early encounters with harmless antigens by the immature immune system more readily enable immune cells to tolerate these harmless antigens rather than initiate defensive reactions to them. The American Academy of Pediatrics no longer advises all pregnant women and nursing mothers to avoid certain foods, such as nuts, eggs, or cow's milk, or to eliminate them from their babies' diets. Women with concerns about their children developing allergies should consult with their doctors. If we consider the source of immunity, that is, where it comes from, we can begin with two major categories: genetic immunity and acquired immunity. Genetic immunity is conferred by our DNA, and acquired immunity is developed or acquired by natural or artificial means. Genetic immunity does not involve antibodies or the immune system. It is the result of our genetic makeup. What this means is that some pathogens cause disease in certain host species but not in others. Dogs and cats, for example, have genetic immunity to the measles virus, which is a pathogen only for people. Mouse leukemia viruses affect only mice, not people. We have genetic immunity to them. This is not because we have antibodies against these mouse viruses, but rather that we have genes that are the codes for proteins that make it impossible for such pathogens to reproduce in our cells and tissues. Monkeys have similar protective genes and proteins for the human AIDS virus. HIV does not cause disease in these monkeys. Because this is a genetic characteristic programmed in DNA, genetic immunity always lasts a lifetime. Acquired immunity does involve antibodies. Passive immunity means that the antibodies are from another source, whereas active immunity means that the individual produces his or her own antibodies. Both passive and active immunity may be acquired naturally or by artificial means. One type of naturally acquired passive immunity is the placental transmission of antibodies, IgG, from maternal blood to fetal circulation. The baby will then be born temporarily immune to the diseases the mother is immune to. Such passive immunity may be prolonged by breastfeeding because breast milk also contains maternal antibodies, IgA. Artificially acquired passive immunity is obtained by the injection of immune globulins, gamma globulins, or performed antibodies after presumed exposure to a particular pathogen. Such immune globulins are available for German measles, hepatitis A and B, tetanus and botulism antitoxins, and rabies. Antibodies to the toxins of Clostridium difficile have been FDA approved to try to prevent relapses of this potentially serious intestinal infection. These are not vaccines. They do not stimulate immune mechanisms, but rather provide immediate antibody protection. Passive immunity is always temporary, lasting a few weeks to a few months because antibodies from another source eventually break down. Active immunity is the production of one's own antibodies and may be stimulated by natural or artificial means. Naturally acquired active immunity means that a person has recovered from a disease and now has antibodies and memory cells specific for that pathogen. Artificially acquired active immunity is the result of a vaccine that has stimulated production of antibodies and memory cells. No general statement can be made about the duration of active immunity. Recovering from bubonic plague, for example, confers lifelong immunity, but the plague vaccine does not. Duration of active immunity, therefore, varies with the particular disease or vaccine. These types of immunity are summarized in Table 14.2. Another type of immunity, called herd immunity, encompasses a population that may be small or large and depends upon the number of individuals in the population who have active immunity to a particular disease. Their immunity may be naturally or artificially acquired. For example, West Nile virus arrived in the United States in 1999 and caused thousands of cases over the next few years. Not any longer. Although we do not know for certain, recovery from West Nile infection, and most people have few or no symptoms, probably provides immunity for several years, if not longer. More people with immunity means fewer hosts for the virus, so it is less likely that the mosquitoes will transfer the virus to a non-immune person. Vaccines do the very same. Let us use the example of measles, a contagious disease in a large city. If most people have been vaccinated against measles, the number of possible hosts for the virus is decreased, and this decreases the chance of exposure for unvaccinated people, especially the very young for whom measles is most severe. The aging of the lymphatic system is apparent in the decreased efficiency of immune responses. Elderly people are more likely than younger ones to develop shingles when an aging immune system cannot keep the chickenpox virus dormant. They are also more susceptible to infections such as influenza and to what are called secondary infections such as pneumonia following a case of the flu. Vaccines for both of these are available, and elderly people should be encouraged to get them. Elderly people should also be sure to get a tetanus, diphtheria, pertussis booster every 10 years. Autoimmune disorders are also more common among older people. The immune system mistakenly perceives a body tissue as foreign and initiates its destruction. Rheumatoid arthritis and myasthenia gravis are examples of autoimmune diseases. The incidence of cancer is also higher. Malignant cells that once might have been quickly destroyed remain alive and proliferate. The preceding discussions of immunity should give you a small idea of the complexity of the body's defense system. Types of immunity. Genetic. Does not involve antibodies. Is programmed in DNA. Some pathogens affect certain host species but not others. Acquired. It does involve antibodies. Passive. Antibodies from another source. Natural. Placental transmission of IgG antibodies from mother to fetus. Transmission of IgA antibodies in breast milk. Artificial. Injection of preformed antibodies, gamma globulins, or immune globulins after presumed exposure. Active. Production of one's own antibodies. Natural. Recovery from a disease with production of antibodies and memory cells. Artificial. A vaccine stimulates production of antibodies and memory cells. In England in 1797, Edward Jenner published his results on the use of the cowpox virus called vaccinia as the first vaccine for smallpox, a closely related virus. He was unaware of the actual pathogens because viruses had not yet been discovered, but he had noticed that milkmaids who got cowpox rarely got smallpox. In 1980, the World Health Organization declared that smallpox had been eradicated throughout the world. A disease that had killed or disfigured millions of people throughout recorded history is now considered part of history, except for the possible use of the virus as a biological weapon. In the 19th century, in the northern United States, thousands of children died of diphtheria every winter. Today, there are fewer than 10 cases of diphtheria each year in the entire country. In the early 1950s, 50,000 cases of paralytic polio were reported in the United States each year. Today, wild-type poliovirus is not found in North America. Smallpox, diphtheria, and polio are no longer the terrible diseases they once were, and this is because of the development and widespread use of vaccines. When people are protected by a vaccine, they are no longer possible reservoirs or sources of the pathogen for others, and the spread of disease may be greatly limited. Other diseases that have been controlled by the use of vaccines are tetanus, mumps, influenza, measles, and German measles. Whooping cough has been controlled until recently when the vaccination rate decreased. With that decrease, the annual number of cases in the United States has increased markedly. The vaccine for hepatitis B has significantly decreased the number of cases of this disease among healthcare workers, and the vaccine is recommended for all children. People who have been exposed to rabies, which otherwise is virtually always fatal, can be protected by a safe vaccine. Without such vaccines, our lives would be very different. Infant mortality or death in childhood would be much more frequent, and all of us would have to be much more aware of infectious disease. In many parts of the world, this is still true. Many of the developing countries in Africa and Asia still cannot afford extensive vaccination programs for their children. Many of the diseases mentioned here, which we rarely think of, are still a significant part of lives in millions of people. Study outline. The functions of the lymphatic system are to return tissue fluid to the blood to maintain blood volume and to protect the body against pathogens and other foreign material. Parts of the lymphatic system: lymph and lymph vessels, lymphatic tissue, lymph nodes and nodules, spleen and thymus. Lymphocytes mature and proliferate. Stem cells are present. Lymph, the tissue fluid that enters the lymph capillaries. Similar to plasma, but more white blood cells are present and has less protein. Must be returned to the blood to maintain blood volume and blood pressure. Lymph vessels. Dead-end lymph capillaries are found in most tissue spaces. Collect tissue fluid and proteins. The structure of larger lymph vessels is like that of veins. Valves prevent the backflow of lymph. Lymph is kept moving in lymph vessels by constriction of the lymph vessels, the skeletal muscle pump, and the respiratory pump. Lymph from the lower body and upper left quadrant enters the thoracic duct and is returned to the blood in the left subclavian vein. Lymph from the upper right quadrant enters the right lymphatic duct and is returned to the blood in the right subclavian vein. Lymph nodes, encapsulated masses of lymphatic tissue, found in groups along the pathways of lymph vessels. As lymph flows through the nodes, foreign material is phagocytized by fixed macrophages. Lymphocytes are activated and fixed plasma cells produce antibodies to foreign antigens. The major paired groups of lymph nodes are the cervical, axillary, and inguinal groups. These are the junctions of the head and extremities with the trunk. They remove pathogens from the lymph from the extremities before the lymph is returned to the blood. Lymph nodules, small unencapsulated masses of lymphatic tissue, found beneath the epithelium of all mucous membranes, that is, the tracts that have natural openings to the environment. Destroy pathogens that penetrate the epithelium of the respiratory, digestive, urinary, and reproductive tracts. Tonsils are the lymph nodules of the pharynx. Peyer's patches are those of the small intestine. Spleen, located in the upper left abdominal quadrant behind the stomach. The fetal spleen produces red blood cells. Functions after birth. Contains lymphocytes to be activated and fixed plasma cells that produce antibodies. Contains monocytes and fixed macrophages, RE cells, that phagocytize pathogens and old red blood cells. Bilirubin is formed and sent to the liver for excretion in the bile. Stores platelets and destroys damaged platelets. Thymus, inferior to the thyroid gland. In the fetus, an infant thymus is large. With age, the thymus shrinks. Produces T lymphocytes, or T cells. Produces other cells and thymic hormones that enable T cells to become immunologically competent, able to recognize foreign antigens and provide immunity. The two aspects of immunological competence are self-recognition for cells and self-tolerance for protein and other organic molecules that the body's cell produces. Immunity, the ability to destroy foreign antigens and prevent future cases of certain infectious diseases. Antigens are chemical markers that identify cells. Human cells have self-antigens, the HLA types. Foreign antigens stimulate antibody production or other immune responses and include bacteria, viruses, fungi, protozoa, and malignant cells. Innate immunity is nonspecific, responses are always the same, does not involve antibodies or create memory, and does not become more efficient, consists of barriers, defensive cells, and chemical defenses. Barriers. Unbroken stratum corneum, an excellent barrier. Microbiota and sebum limit other bacterial growth. Living epidermal cells secrete defensins. Subcutaneous tissue with white blood cells. Mucous membranes and areolar connective tissue with white blood cells. Upper respiratory epithelium is ciliated. Hydrochloric acid in gastric juice. lysosome in saliva and tears. Defensive cells, phagocytes, macrophages, neutrophils, eosinophils. Macrophages also activate the lymphocytes of adaptive immunity. Langerhans cells and other dendritic cells activate lymphocytes. Natural killer cells destroy foreign cells by rupturing their cell membranes. Basophils and mast cells produce histamine and leukotrienes for inflammation. Chemical defenses. Interferon blocks vital reproduction. Complement proteins, lyse, foreign cells attract white blood cells and contribute to inflammation. Inflammation is the response to any kind of damage. Vasodilation and increased capillary permeability bring tissue fluid and white blood cells to the area. Purpose: to contain the damage, eliminate the cause, and make tissue repair possible. Signs are redness, heat, swelling, and pain. Adaptive immunity is very specific and may involve antibodies, does create memory, and responses become more efficient. Consists of cell-mediated and antibody-mediated immunity, is carried out by T cells, B cells, and macrophages. T lymphocytes, or T cells, in the embryo are produced in the thymus and red bone marrow. They require the hormones of the thymus for maturation, migrate to the spleen, lymph nodes, and nodules. B lymphocytes, or B cells, in the embryo are produced in the red bone marrow, migrate to the spleen, lymph nodes, and nodules. The antigen must first be recognized as foreign. This is accomplished by B cells or by helper T cells that compare the foreign antigen with self-antigens present on macrophages. Helper T cells strongly initiate one or both of the immune mechanisms, cell-mediated immunity and antibody-mediated immunity. Cell-mediated or cellular immunity does not involve antibodies, is effected against intracellular pathogens, malignant cells, and grafts of foreign tissue. Macrophages and helper T cells recognize the foreign antigen. Helper T cells are antigen-specific and begin to divide to form different subsets of T cells. Memory T cells will remember the specific foreign antigen. Cytotoxic or killer T cells chemically destroy foreign cells and produce cytokines to attract macrophages. Regulatory T cells stop the immune system response when the pathogen has been eliminated. Antibody-mediated or humoral immunity does involve antibody production, is effective against pathogens and foreign cells. B cells, macrophages, and helper T cells recognize the foreign antigen. The B cells are antigen-specific and begin to divide. Memory B cells will remember the specific foreign antigen. Other B cells become plasma cells that produce antigen-specific antibodies. An antigen-antibody complex is formed, which attracts macrophages. Opsonization. Complement fixation is stimulated by antigen-antibody complexes. The complement proteins bind to the antigen-antibody complex and lyse cellular antigens or enhance the phagocytosis of non-cellular antigens. Antibodies, immune globulins, Ig, or gamma globulins. Proteins produced by plasma cells in response to foreign antigens. Each antibody is specific for only one foreign antigen. Bond to foreign antigen to label it for phagocytosis or opsonization. Antibody responses and functions. On the first exposure to a foreign antigen, antibodies are produced slowly and in small amounts, and the person may develop clinical disease. On the second exposure, the memory cells initiate rapid production of large amounts of antibodies, and a second case of the disease may be prevented. This is the basis for the protection given by vaccines, which take the place of the first exposure. Antibodies cause agglutination or clumping of bacterial cells. Clumped cells are easier for macrophages to phagocytize. Antibodies neutralize viruses by bonding to them and preventing their entry into cells. Antibodies neutralize bacterial toxins by bonding to them and changing their shape. Types of immunity. Herd immunity, the protection provided for non-immune persons in a population by the presence of an immune majority. Classes of antibodies. IgG, blood and extracellular fluid. A monomer, the most abundant immune globulin, crosses the placenta to provide passive immunity for newborns, provides long-term immunity to a disease following recovery or a vaccine. IgA, external and internal secretions, tears, saliva, intestinal, etc. A dimer, present in breast milk to provide passive immunity for breastfed infants, found in secretions of all mucous membranes to provide local defense where pathogens enter. IgM, in blood, a pentamer, produced first by the maturing immune system of infants. Produced first during an infection, IgG production follows. The antibodies of the ABO blood group. IgD, B lymphocytes. A monomer, forms receptors on B lymphocytes. IgE, mast cells or basophils. A monomer, is important in allergic reactions. Mast cells release histamine and responses to parasites such as worms.